All right, everybody. Very excited. We have the world's best, and also we have the best in the United States. Here, the following, I will introduce Dr. Busui, Rodica Busui, and she's our keynote speaker of today also. And Dr. Busui is professor and chief of the division in endocrinology, diabetes, clinical nutrition, and the director of Diabetes Health Center at Oregon Health and Science University. And she is 2023 President of Medicine and Science of American Diabetes Society. So she is an international renown. And so we are so glad and so honored to have you.
Thank you.
Well, good afternoon, and first of all, thank you so much, Ellen, for the very kind introduction and for inviting me to be part of this exciting meeting. I was asked to give you some perspectives on the diabetes epidemics and how that actually merge with the diabetic foot complications, which are obviously the interest of this forum and the interest of your practices. And here are my disclosures. I would also like to say that probably the most important disclosure is that I'm probably the only non-surgeon here. I am an endocrinologist and diabetologist, and I have dedicated my career to make the life of people with diabetes better. What I'm going to talk about is just give you a little bit more perspective on the overall global burden of diabetes and diabetes complications. And then, of course, highlight that unlike any other wounds or surgical challenges, diabetes is very different and very complex because the entirety of this medical problem. I'd also like to discuss with you some research evidence based data that demonstrating why is it so hard to actually treat the diabetic wounds and diabetic complications, and then give you some perspective on what we can do working together as a team and where is the research going. So let's talk about the data on the burden. I don't know whether all of you are aware, but right now we have about 600 million of people with diabetes in the world, and we unfortunately have just passed the 40 million of people with diabetes in the United States. We have about 41. What does it mean? It means that in general, in most of the states, more than 10% of the population has diabetes, and there are states that actually have close to 15%. And why is it important? It's because the costs are non-sustainable. This is most recent data that had been done by the American Diabetes Association working together with the Centers for Disease and Control and the National Statistics, demonstrating that diabetes is now not only the most prevalent chronic disease in this country, but it's also the most costly disease. So why is that? Well, it's because in diabetes, this hyperglycemia leads to a plethora of comorbidities. And perhaps most of you are aware of the traditional one, the eye, the kidney, the neuropathy, and I will talk more about neuropathy because that has been the focus of my career for many, many years. And then definitely cardiovascular disease. Diabetes is the leading cause of cardiovascular complications, whether it's atherosclerotic cardiovascular disease that leads to MIs, myocardial infarction, strokes, or PAD, but it's now also the leading cause of heart failure. However, what we have also learned by studying for the last decades is that there are more that it's happening to our patients, and we need to understand the entire complexity in order to deliver the best care. We know now that diabetes is the leading cause of cognitive impairment and Alzheimer, and of depression and anxiety, and reduced function and mobility and quality of life. But we also know that diabetes, unfortunately, is the leading cause of urologic and sexual dysfunction, which for many years have been kind of forgotten or not being asked. And we have now very strong evidence from large cohorts of both people with type 1 and type 2 diabetes demonstrating these facts. And that's why when we look at the food complications, we need to understand that diabetic foot disease does not appear in isolation. And whereas the peripheral neuropathy and peripheral arterial disease, or PAD, and the microvascular dysfunction are definitely key components, everything else, in fact, will contribute to the development of these complications. So if we put the numbers in perspective of 600 million worldwide, we know that at least 80, 90 million, in fact, are at risk and have diabetic foot complication. Again, diabetic foot and diabetes complications are an epidemic, and they are the most challenging chronic disease. What we have learned also is that, of course, we have made a lot of progress in treating diabetes. And the way that we have targeted our intervention is to prevent the consequences of the disease. And I share with you some of these very serious consequences, including cardiovascular disease, kidney, and amputations. And what we see here in this slide, it's actually data that has been revamped most recently, looking at the US population, is that for a number of years, we have made steady progress in reducing the incidence of this most serious complication, as you can see here, across all these various age stages. However, what is worrisome is that despite this progress, there is now an inflection point, particularly which is affecting the younger patient. And that's very important as well, because these people have supposedly a longer life expectancy and therefore a higher risk for developing even more severe complications. So why is that? So as I shared with you, we have made advances in better glucose control. In fact, over lunchtime, I had a very nice conversation discussing about all these newer medication that we have been able to discover and demonstrate that they are effective. We have better blood pressure control, better lipid. We have all these technologies, and we understand that, you know, we need to work as a team, but there is still a persistent gap. And one of the gaps is obviously that perhaps many patients in this country and over the globe may not be identified early enough. That's one. Secondly, they may not have access to all this knowledge and all these new medications and all this new technology that we have. And therefore, these gaps contribute to more severe disease that leads to diabetic foot complications that may sometimes be so late that will not be able to be addressed conservatively. So that is why we have such an important work to do. So let's talk a little bit about key drivers of limb risk here, and then concentrate on some of the known risk factors and highlight perhaps some that may have been overlooked. This is what diabetes does in the human body. Diabetes actually stimulates a very early aging through the entire vascular limb tree, starting with the brain and actually going all the way to the limbs and the feet. And that is why it's important to understand that when this vascular aging that can start even before the blood sugar levels actually reach that threshold that is diagnostic for diabetes, will lead to these continuous pathways of progressive vascular injury and multiple organ complications. So also very important, a key message is that these complications do not occur in isolation. And I like to highlight a lot. I remember when I was an early faculty and I wrote my first grant looking at several complications at the same time, a reviewer actually didn't score the grant saying, well, you have to concentrate on one complication because it's not like people with diabetes develop more than one, and that is so wrong. And we know now that, in fact, it's most likely that when you have vascular disease, you will have impairment in the kidney, in the heart, in the brain, even if some of them may be at a much lower clinical level that may not be easily detected. And that is why now we are no longer talking necessarily about diabetes. We are talking about this cardio-kidney metabolic disease, because as you can see here, hyperglycemia is one of the key promoter of this vascular dysfunction, but it acts in concert with insulin resistance, with inflammation. Like, for instance, we know that majority of people with diabetes have type 2 diabetes and have obesity, or they are overweight. This adipose tissue, these adipocytes, are not neutral cells. In fact, they are actively producing all these inflammatory cytokines that do further contribute to drive the vascular injury. And that it's affecting, as you can see, a much more progressive plaque that it's happening both at larger vessels and smaller vessels. So one of important key message is that in diabetes, organ systems do not fail independently. They fail together, and they go progressively to that. Let me talk a little bit more about the kidney. Why is that? Of course, we know that neuropathy and PAD are important, but you will actually be convinced that once you also have kidney disease, that further amplifies this risk, because diabetes, kidney, heart, and the limb are, as I showed, intertwined in this cardiorenal. And as you can see here, in diabetes, this inflammation, endothelial dysfunction, microvascular disease, impaired angiogenesis, all are also contributing to impaired tissue repair in the presence of a wound. And therefore, I think it's very important when we evaluate a patient with a wound, and in case you may be the first person to evaluate that person with diabetes, just keep in mind that we need to understand the entire complexity of vascular and organ involvement in order to have the highest chances to promote healing in that particular patient. Diabetic foot, it's not only a vascular complication, it's part of this entire cardiorenal metabolic risk. And that is why being aware and screening early, it's a key component of how we can be successful in driving an outcome of interest. Of course, peripheral arterial disease is very important. And I have to say that I'm very proud that in the last 2 years, the American Diabetes Association that it's publishing the standards of care for diabetes is now including active screening for peripheral arterial disease in people with diabetes. We had a lot of pushback for some of you who are not aware, from some community members from various backgrounds questioning the cost effectiveness of this recommendation that we stand by, because the earlier that we identify the disease, the better the chances to intervene. And then again, I don't need to show you how this tissue ischemia that is superimposed on the wound can much quickly amplify this amputation and mortality risk. I'd like to spend a couple of minutes talking about diabetic peripheral neuropathy, not just because I have spent a lot of time in my career to study this complication. And here is data that we have now obtained by studying more than 50,000 of people with diabetes, both type 2 and type 1. Here in the United States, I have been very fortunate to be key investigators in the most prominent type 1 diabetes cohort like DCCT EDIC, TUND exchange, as well as across the world and working with our European colleagues. And we know that as we speak, about 50 to 60% of people with type 2 diabetes have neuropathy, and about 35% of people with type 1 diabetes have diabetic neuropathy. And why is this important? As it has been alluded earlier this morning, Diabetic neuropathy is in fact the leading cause of diabetic foot ulcerations, and neuropathy is complex. And as Dr. Manu had said, we do not have disease-modifying therapies to date. We have large fibers. They are responsible for vibration, proprioception, and light touch. We have small fibers that are driving the perception of pain and temperature discrimination. And then, of course, we have autonomic fibers that innervate the heart, the kidney, the urogenital system, the skin. So it is very complex, it's true. But because of this progressive damage and loss in all this population of nerve fibers, obviously people with diabetes have impaired sensation, and that impaired sensation is the most important reason of this continuous repetitive trauma that lead to foot ulcers, which are, as I will demonstrate in a bit, also very likely to get infected and then being so much more challenging to treat. So overall neuropathy, because of the loss of sensation, it's also leading to loss of balance, risk of falls and fractures, definitely ulcers and infection and amputations. And because of the link with amputation and through the autonomic component that I don't have time to talk about today, it is one of the confirmed independent risk factors of mortality in diabetes. And that's very important component is that the pain perception is impaired in diabetes. So people do not develop ulcers because they feel too much pain, although they do feel pain, as I will demonstrate. They develop the ulcers because that protective pain sensation is absent or very much reduced. And here is the neuropathy paradox, because people are losing the ability to sense the pain. However, they develop neuropathic pain, which is extremely challenging to treat. They have this burning, lancinating pain that, as you can see here, does induce an entire plethora of consequences, including sleep disruption, polypharmacy, unfortunately, even for pain. And, we do have medications like pregabalin and gabapentin that are, level 1 medication for pain reduction. And I want to make it very clear. These medications have no effect whatsoever on reversing any nerve damage or even preventing nerve damage. They are only approved to treat neuropathic pain. But even these agents are not effective, and they have a lot of side effects in the effective dosing. Definitely reduce quality of life, social impact. And as you can see here, neuropathy is a conundrum and is the reason of diabetic foot ulceration. So let's review a little bit more some of these mechanisms that are associated with poor healing in people with diabetes. And here is just to summarize all these factors that contribute to ulcers and poor healing, just as a summary, but I like to spend a couple of minutes on infection. So what's happening in diabetes? Besides all this continuous vascular aging, there is a progressive compromise of the immune system. Hyperglycemia is basically affecting the immune system. It's affecting the inflammatory pathways, including chemotaxis, oxidative stress, that all do lead to this impaired host defense, and poor perfusion further amplifies all this chronic inflammation there, then actually creates the perfect milieu, the perfect storm for this polymicrobial infection. And I know that in your practice, probably you have demonstrated this over and over again, that the reason that infection is so difficult to treat in diabetes is just because it's not just one type of germ. As you know very well, there are gram-positive, gram-negative, and anaerobes in a various combination. Plus, the way that we can identify infection, it's still quite antiquated, unfortunately, taking like several days, maybe 7 days to get a culture, when in reality we also know from research that the early we intervene to treat infection and more targeted we do, the most likely it is to be successful. So therefore, the infection is one of the major reasons of lack of wound healing in people with diabetes. But there is more than just infection. Right? As I mentioned earlier, we do have this inflammation, the chronic inflammation, which is associated with the diabetes state and this progressive vascular, the oxidative stress, all these free radicals that people with diabetes have, even when they don't have a wound. There are all these impairments in growth factors, signaling that, as you know very well, are essential to promote healing. And yet in diabetes, it's not like a 20-year-old who has a wound because they had a small burn. It's very different. The growth factor signaling, it's impaired. The same, all these healing mechanisms that involve as profoundly as the mitochondria and the autophages are impaired in diabetes. And that is actually leading to this vicious cycle, which is continuous in a person with diabetes, further amplifying the lack of response to traditional way of wound healing. That's why we need to change completely the paradigm. But there is more than just biology, and I have to address the access to care and risk of limb loss in diabetes. This is the most recent map that the American Heart Association had published, looking like a heat map on what are the areas of United States with a higher risk for amputations. And as you can see here, the Deep South, unfortunately, it's called like the hot belt of amputations, because there is a much higher prevalence of diabetes, as you can see, 13 to 14% in these states. So therefore, the risk of having complication is much higher. But there is a lack of access to specialized care, the lack of patient health literacy, lack of, unfortunately, education of many providers on what are the critical essential steps in providing this cost-effective limb-saving therapies. And all this plethora of limited access, delayed screening, delayed diagnosis, delayed wound care, the superimposition of infections are leading to amputation. And Mississippi is the state right now, unfortunately, which leads the pack. So if we look again at another way to looking at the data, if we look at the incidence and risk for developing foot ulcers here on the left, you can see that still the prevalence of foot ulcer is higher in white, non-Hispanic white. And yet, if we look compare with Black, Hispanic, or others, the likelihood of amputation is the lowest in non-Hispanic white, with the highest in Black, followed by Hispanics, and then other racial disparity. So that's something else that needs to change. And when we look at that data, we realize that unfortunately, even in this country, not everyone who has a diabetic foot ulcer has the same chance of keeping a limb as demonstrated. So we need to look beyond biology when we evaluate a patient, and making sure that we address glucose, that we educate them about neuropathy. Unfortunately, we cannot reverse the nerve loss, but we can educate about the consequences, screen for PAD, and make sure that maybe a person needs revascularization, that it's offered to them before an amputation, treat the infection, treat the kidney, and treat the heart. Because if we don't treat the kidney and the heart, this chronic inflammation is just going to persist. And diabetic foot complications matter. I don't need to rehash. This is just a summary why a foot ulcer can easily lead to amputation and mortality if action is not taken in very early stages. But I also like to share with you, unfortunately, kind of grim data of why wound healing therapy have not succeeded so far. So when we develop a medication, we obviously look at the biological pathways and the mechanism, and then we actually design a trial to reverse that. But what's happening here is, unfortunately, when many biological models like the animal models, were completely irrelevant to human disease. And that was true for kidney and the heart, but it's also true for wound healing, because in mice, the wound healing mechanisms are very different than in humans, and yet many therapies have been developed using mice model. There is also a lack of validated biomarkers. We have not known until we don't know even now, but hopefully soon, why some ulcers will heal and some will not. Which patients will respond to a given therapy, and how to design trials that are not just cherry picking many of the wound healing. We have more like 200 wound healing products that we can apply on the heel, and yet the amputations in the United States increased by 60% last year, which is unacceptable. It's because when you design a trial, you cannot cherry pick ulcers that will heal anyway. And because of the FDA pathway for this local therapy, it's much more lenient compared with a systemic medication that contributed. So we need precision wound healing. And that's why I want to introduce the Diabetic Foot Consortium, of which I have the privilege to be the chair. This is a largest NIH-funded multi-site consortium that is testing exactly that. Which are the phenotypes of people who may heal? Which are the biomarkers that can tell us about healing, and how we can stratify and how we can best design trials, and we have recruited about 1,000 people to date. So what works? Prevention works, and I don't need to highlight too much longer that we need to work as a team. We know that there are several components: preventing neuropathy, preventing complication, preventing foot ulcers once a complication occurs. And I just like to end to say that diabetic foot care does not require one provider, requires the entire team, and definitely the podiatry, the endocrinologist, and the multidisciplinary safe limbs. So I like to end by giving you these few take-home messages. Diabetes is the most serious chronic disease epidemic here in the United States and worldwide. Foot disease remains devastating. I didn't put the data here, but 60% increase in amputation in US only last year. It's something that should have never happened. The foot reflects systemic disease. So when you see a person with foot, think that there is so much more there. Prevention works. Early detection, early screening, and multidisciplinary care save lives. And then, of course, health disparities unfortunately matter. And with that, thank you so much for your attention.
All right. There. Thank you very much, Dr. Busui. Appreciate your comments. Thank you very much. We'd like to take a minute to recognize somebody real quick before we move on to our next speaker. Dr. Alan Yan has been working extremely hard and spearheading this project, and it's been his baby, turned from a small idea into what you see right now. So if you could join me in an applause for Dr. Yan. Thank you. Now it's my pleasure to introduce my friend and colleague, Dr. Meredith Hayes. Dr. Meredith Hayes went to school at the University of South Florida and did her residency in radiology at Mayo Clinic in Rochester, Minnesota, and she also completed her fellowship in musculoskeletal radiology there. Interesting fact about her, so she actually started her career path as an orthopedic surgeon. She was in her orthopedic residency, then unfortunately she sustained a spinal injury, causing her to change her career path. But we're very fortunate to have her. She works with us at Sanford USD Med Center, and I'll turn the time over to Dr. Hayes.
So I'm going to be speaking on modalities, algorithms, and challenges in MSK imaging and diabetic foot disease. And just from the go ahead, because we'll just call Charcot CNO and we'll call osteomyelitis, OM. And I want to give thank you to my my husband. He's also a MSK radiologist. We met during residency, and he helped me tremendously with this talk using the abilities of AI to kind of change the talk. So we'll just get started. So I have 4 learning objectives, basically imaging of Charcot neuropathy or CNO. And then we're going to talk about how to differentiate CNO from CNO with osteomyelitis. That's one of our biggest challenges as a radiologist, to figure out which is which. And then we're going to talk about novel imaging that we have in at Sanford and across the US and the UK. And then we're going to go on how to communicate with us. It was always the old school, pick up the phone and call us. And now we have a much more electronic system where you end up chatting with us. But, and I'll go through that in a second. So why does this matter? And so the big thing is when you have Charcot arthropathy, we're trying to prevent amputation. That's the goal. And so whenever you have a patient that comes in and they're diabetic and they have a red hot foot, you go instantly, is this Charcot, and what do we do? And so the big thing is we want to put them in a boot, and we call this thing the crow boot. And I always like to pimp the residents on what a crow boot, you know, what does it stand for? And it stands for Charcot restraint. It's difficult for me to see from behind there. Charcot restraint boot. And so you've seen the pictures of the boot when you guys walk around and go at O&P. And so you put a lot of patients in these boots just to protect them. And so we're going to start with the imaging of CNO. And the answer is it's not one scan. It's an algorithm, as we talked about. And so the first step, as always, is get an X-ray. Okay, and we want to get an X-ray both the foot and the ankle. And so we get X-rays according to your guidelines, the working group guidelines. We get imaging of the foot and we get imaging of the ankle. Our typical series for a foot, we got an AP, an oblique, and a lateral. And we get our series for the ankle is the AP, the oblique, and the lateral. That's how we cover both sets of images. What we're trying to prevent is a patient going into end-stage Charcot arthropathy. That's the whole goal of this whole conference. And so what are the actual stages of Charcot arthropathy in the working group? And so you go by Eichenholz. Hopefully I won't mangle his name, Eichenholz. Thank you, our Dr. Nichols, he helped me with the name. So his classification system. And so normally in ortho, I always learned there was 4 stages, but when you go for the radiographic and the clinical, we go from a 0 to a prodromal phase, and then you go all the way to healing if they're in a boot. Okay, we'll just say if they're in a boot. So you go from this stage 0, stage 2, stage 3, and stage 4, or sorry, stage 3. So we'll just kind of go through what does these actually look like radiographically. So stage 0 in the prodromal phase, this is when the patient comes in, they have that red hot foot. The X-rays are usually absolutely normal, okay? And then when you start going on to the fragmentation stage, this is when you start getting the dislocations. And the dislocations always happen in the midfoot. That's where all the Charcot arthropathy happens. And it almost looks, if this was a trauma patient, this would be a Lisfranc injury if you didn't know the history. And so you get the dislocations, we always learned the 4 Ds in radiology. You get the dislocations, you get the debris or these little tiny calcifications. And so you're moving on, now they're starting to heal. They're going into stage 2 and you get more increased density. So they're starting to heal and you want them to heal. And so once you finally hit that coalescence or healing stage, they actually start to heal the fractures and it developed more sclerosis or increased density. And so this is good. We healed them, we put them in a boot, but it's not always like that. So we kind of talk about a continuation. So you go from stage 0, this prodromal phase, and then they start to heal in the boot. But the problem is that it can go backwards, okay? So if they don't heal and they don't wear their boot and you go, uh-oh, they've gone from this healing stage and then they've gone backwards back into the fragmentation stage. So now you're acute on chronic. So now what do you do? Okay. So in imaging, we want to stop. Okay. We're trying to figure out how to stop from going from a prodromal stage in order to make them heal. And so the goal with this, according to the working group guidelines, is that's where we intervene with an MR. And so the MRI, we have several different, we always like to have toys in MRI. We have our chimney coil that we like to use. That's what we put our foot in, and it looks like a chimenea. And we prefer the 3T is always better than the 1.5, the higher strength, the better. And then for the sequences are always a T1 and a stir. And the reason why is because if you go to a stir image, if you have feet or toes that are curled, you get really bad fat sat. And that's gonna become a problem because you're gonna lead to false positives, false negatives. So stick with the T1s and stirs. And so this is what a prodromal phase looks like, okay? You have negative X-ray on the top, and below you get all this marrow edema and the soft tissue edema. You get edema of the tendons, and you go, what is this? But if you have the history, you go, this is prodromal phase. This is where we want to catch it before they go on to start to dislocate. So this is another case, prodromal. This is what we're trying to catch. Prodromal, negative X-ray, and then now you have the MRI that has all the bone marrow edema and the soft tissue edema. However, when you start to go, let me back up. This is where we differ a little bit on the working group guidelines. So the working group guidelines say we don't need contrast. Well, the radiologists love contrast. And what helps us out and find everything. And the reason why is when they're in this prodromal phase and they have all this weird patchy marrow edema in the midfoot and the soft tissue, it can look like anything, like ARDS or RDS, sorry. So we want to give them GAD because contrast, we radiologists love to give the GAD. And the reason why is because this periarticular enhancement gets way more apparent. Okay, and also if you're trying to rule out osteomyelitis in the case of CNO, you want to make sure that they don't have an abscess. And so if you give the GAD, it gets it all in one shot. And so we love to give the GAD to rule out the osteo. So now we're hitting into stage 2. We moved on to stage 2 or this fragmentation stage. And the image on the top is when you start to get fragmentation stage in that midfoot, okay? And then on the bottom, that's when you start to get the dislocations of the bone. And it's always the TMT joints. It looks like a Lisp fracture, okay? Now we're starting to heal, keep it in the boot, okay? And now the healing stages of Charcot, you get these little cystic changes around the joint, and you also get these little osteophytes always on the dorsal aspect of the tarsal bones. And it looks like, okay, we're doing pretty good. We're healing. However, how do we differentiate when patients start, if they get, the big thing is, do they have an ulcer or not? That is the big key to differentiate osteomyelitis, CNO, and just regular Charcot, okay? But that's the biggest challenge. So we're going to take a step back and how do we manage this algorithm? And again, we always start with the X-ray. X-rays are always the first beginning. This is your Charcot arthropathy. You got the dislocations, the 4Ds. This is your osteo, okay? If you can see it, let me see if I can, if there's a pointer. If you look by the 5th metatarsal base, there's localized osteolysis by an ulcer. This is the classic for osteomyelitis. However, our big friend, we love MR. We're radiologists, we're gonna get an MR. And so how do I differentiate the two, the CNO versus CNO with OM? And the big thing is ulcer. If they don't have an ulcer, it is going to be Charcot. If they have an ulcer, then you got to concern yourself about osteomyelitis. So here's the big thing. Patient comes in, they have an ulcer. And if they have this ulcer adjacent to the localized marrow edema in a specific bones that's next to the ulcer, that tracks down to the ulcer, that's going to be your osteomyelitis. And then on the T1 weighted images, you get this mirror placement. So on the T1 images, it looks dark, okay? So moving on, the other quick sign, that's also, if you can see the little arrow, that's my little chimney coil sitting on the side. But there's also this ghost sign, okay? And you go, what is that? And you go, that's when I give GAD, when I have an MR. And so when I have an MR, I give the GAD. If you look on the image, it says T1 minus. That's a T1 weighted image with no GAD. You see all that dark mirror replacement. It looks ugly. But where exactly is the osteo if you have to go to surgery? So you give the GAD and you go, oh, now you see where the osteomyelitis is. That's why we give the GAD. And so that localizes to the surgeon of where they need to go, where they need a biopsy. And so that's why we call it the go sign, because sometimes it's there and we give the GAD and it's there. So nuclear medicine, this is a whole new ball game. And that's where I have the little dude with the little squinty glasses, because you have to put your imaginal glasses on once you start getting into the nuclear imaging world. Okay. And so what I want to focus when I start talking about nuclear imaging, okay, there's 3 scans that we do in nuclear imaging. There's a bone scan, there's a sulfur colloid scan, and there's a white blood cell scan. And they do all 3. You have to do all 3. You call it the triple scan. I like to call it the trifecta. Okay. And so basically the bottom line is, after all this, after doing all these scans, is the only one that matters the most is the white blood cell scan. And that's how you differentiate CNO versus CNO with osteomyelitis. Okay. And so put on your little imaginal glasses. And what I wanted, this is my key point before moving on. Anything like the bone scan, the sulfur colloid scan, and the white blood cell scan, I can add a CT to any of those, and it gives you fancier images. So that's my picture at the bottom. You can put a bone scan, you stick it in the CT scan, and then we call this fancy name called SPEC CT. So bone scan and SPEC CT are the same thing, just with the extra added CT, so better imaging. So my big focus is just go right to the blood cell scan, and that's where you get your findings. So put your imaginal glasses on, and so the images that are on the left-hand side, you got your bone scan on the top, you got your SPEC scan on the bottom, and you go, wow, that's nice imaging, it's hot. What is it? You don't know. It could be either one, okay? And so that's why the information that it gives you is not so great. But when you put it with the, let me go forward, the white blood cell scan, and there's a little dot right where the arrow is, okay? That's where the osteomyelitis is. And so bottom line is, that's what matters, is the white blood cell count. People also move on and they go, can I do a PET CT? This is where we get into, this is very expensive and it's not readily available, and it takes a gosh long darn time to get a PET CT, a PET CT. So if we label it, remember our white blood cell scan, that's our friend, and we put it in the PET scanner, yes, this is going to give you massive sensitivity and specificity, but the likelihood that you're going to get the scan in enough time is pretty dang rare, and it's very expensive, okay? So let's do a little bit of the future stuff, because that's what's fun, okay? So MRI at Sanford and across, some certain other institutions, we can add what's called a ZTE image. And it's basically this fancy software that we can use to make an MRI look like a CT. And so it saves us a lot of time, because we can get both scans at the same time, okay? And so the image on the left, that's your MR, that's your T1, and you can't tell, but the images that are on the right, that's coming from an MR, and it's what's called a ZTE, and it's basically a fancy word because we couldn't call it CT. We call it ZTE because the Z was what the algorithm was using in the background. So it gets 2 images all in one, okay? Now we're gonna talk about weight-bearing CT. We have that here at Mayo. You have a curved beam, they get into a scan and they sit and they stand. And so it's a CT and you weight bear, and it brings out even more information of, is the TMT joints, are they spreading out? Do I have more fractures? Is there dislocation? Is there debris? The 4 Ds of Charcot. So now we get an even fancier. Now we start doing 3D measurements. And so from that weight-bearing CT, we can make 3D images, and we can also 3D print. So in orthopedics when you're going into surgery, you got these fancy 3D models that you can practice on, you can make certain cuts, and you go, okay. And then when you print out the 3D modeling, that's even better. Now they can take this into the OR and go, this is even better. I know where I'm gonna take this out or fuse or, so moving on, my last objective, because I've got 1 minute, is talking about how do we talk to each other between MSK radiologists and the referring physicians, okay? The old school was you picked up the phone. That was how I was trained. But now it's putting everything you can on the electronic requisite. So basically the bottom line is tell me as much as possible. The big thing is location, location, location. You know, when you're buying real estate, if they have an ulcer, where is it? Is it in the hind foot? Is it in the midfoot? Is it in the forefoot? Because that lets us specify, because you don't want to do the whole foot and because you're just kind of shooting in the dark. So if you say, I got a big ulcer and it's in the hind foot, it sounds weird, but we order it as an ankle, okay? And then if I have an ulcer in the toes, I'm going to image the forefoot, and then it gives you more sensitivity. So if you tell me on the requisite where it's at, and you go, okay, I know where it's at, tell me if you have a high suspicion, and that also helps me out. So that's my talk. I made it in time, and like you said, the big thing is I want to thank also Dr. Yan for all he's done or helping us out and getting this all together. And we'll answer questions later. Thanks. That's all I got.
Thank you, Dr. Hayes. And as she mentioned, we'll just hold questions until the end, and just in the interest of time. It's my pleasure to introduce our next speaker, Dr. Geno Tai. Dr. Geno Tai is an assistant professor of medicine in the Division of Infectious Diseases and International Medicine at the University of Minnesota Medical School. He's board certified in internal medicine and in infectious disease, and his clinical and academic focus is orthopedic infectious disease. So we're pleased to have Dr. Geno Tai. Thank you.
Everyone, thank you for the kind introduction, and it's a pleasure to come here. It's my first time coming here in Sioux Falls. It's wonderful. I guess I want to start by maybe just assessing the crowd and see like how many of you guys are surgeons with a raise of hands? Okay. And anyone internist? The rest are internists or no internist? No ID. But yeah, so I just want to, these are some of three of my objectives today, and I don't want to really bore you in so much details with infectious disease. You can always pick up the phone, ask your colleagues. But because the theme of this conference is about multidisciplinary care teams, so I want to help you apply structured communication strategies to resolve differences between ID and surgery, and then you want to know how to select and interpret appropriate sampling and risk tools to diagnose diabetic foot infections and osteomyelitis, as what Dr. Hayes has discussed already previously with regard to radiology. And, I want to just update you a little bit on what the antibiotic therapy, what are the standards of care right now. And, so those are free. And so I want to start with collaboration, because I think this is usually one of part which is like a pain point with a lot of teams. And we want to start with saying that, a lot of these non-productive conversations between ID and surgery usually fall within three distinct traps. And these are, number one, are communication gaps. We usually rely a lot now on electronic consults. And then for some big institutions and big teams, like for example, in my team, which is like a quaternary hospital, we have my team as a medical student, a resident, and a fellow before me who would communicate with the surgical team who was a medicine, with a medical student, resident, and before the attending. So you can imagine the risk of information leakage and all of those, transfer of like information. The next one is sometimes we have conflicting assessment of just like, likelihood of saving the foot, for example, or healing this ulcer, or how much the antibiotics will work on this specific case. And then there's conflicting values sometimes. So like, well, antibiotic stewardship versus like preserving function. So, and then you can always hear someone, why don't you just amputate? Or like someone would say, why don't you give antibiotics forever? So like those are very different, recommendations. So we want to, like, as much as possible, want to try to connect to our colleagues directly. If there's miscommunication, usually sometimes, and it's, it's just how we're trained, right? Like there's because of information leakage, if there's miscommunication, you want to pick up the phone and just call directly, attending to attending. And then if, there's differences in opinion of prognosis, you want to ask this question of like, try to be open-minded and say, walk me through your assessment. Like, instead of saying, why are you not doing surgery? Or why can't you just give him antibiotics forever? And then I usually personally think you want to assume there's a missing piece of the puzzle here, rather than we're assuming that, oh, this person is incompetent. It's like, okay, what are we missing, and where are we miscommunicating here? So I think those are some very helpful tips to try to communicate between these specialties. And there's already been, it's the Wi-Fi criteria classification has already been discussed. So I would suggest for those building their own teams, or like who doesn't have really strong teams yet in their facilities, to get together and say, okay, we're going to use the Wi-Fi classification, or we're going to use, moving forward, we're going to use the working group definition in our charting, so that when we say, oh, it's class this or like this, then we're all in the same classification system. And also and I tell this to my colleagues in infectious disease, infection control is not the only thing that's like important in life, right? So function of the patient is also quite important to them. Like not everything revolves around, it's like just eradication of infection. So, and our surgical colleagues have, they know more about the biomechanics, the weight-bearing surfaces, how difficult the surgery is going to be. So for us, it's important to actually know those as well and hear from their perspective. This is the classification which I use personally, so the International Working Group, but you can use whatever you choose, or you can use both as well. For the diagnostics, why do we keep asking for cultures? And I teach this to our rule of thumb in a dirty trick is like, how do you choose antibiotic? The antibiotic choice itself is based on the pathogen and the microbiology. And the duration is based on the disease. So to put that together, if you don't know the microbiology, you're already missing half of your plan. You don't know what antibiotics to give. So in this study, for example, of 70 specimens, 41 out of the 45 were the positive culture, antibiotics were changed. But if you took out like 41 out of the 70, that's around 59% only of all who needed cultures. So, but still, if it's positive, it's very helpful. Why don't we just use superficial swab and not get a deep one? There's poor concordance. So you can see here the range is about 19 to 38%. And they always say it's like superficial swab cultures should be avoided. I have to be honest, but sometimes I do that myself. But I think if you do that, just make sure you label it correctly, and you label it, make sure that you label it and say, so that we all have an understanding, oh, this is superficial swab, and you can interpret it better later. So more on the poor concordance, you can see here. So if you see staph aureus or the gram positives, they're usually concordant. they're usually going to show up in the deep ones. But if you see the gram-negative ones, they usually don't show up in the deep ones. So that's where this poor concordance is. And as you know, not all of our antibiotics would treat both, right? And so if you don't know that, you will end up treating a lot of gram-negatives if they don't need that. This is just another study on the same topic. It's 42% concordance rate. How about treatment? So usually, and this is usually the question of well, if they're sick, they have fevers or they have pain, they come into the ER, do you give them antibiotics already before getting deep cultures? Because we're not always there at the bedside, right? We usually come the next day or the day after to be able to get deep cultures. So unfortunately, when we give empiric antibiotics, it makes the cultures problematic. It will make it unreliable. So, but we don't really have good evidence in this area, diabetic foot infection, if it really affects. However, practically speaking, if you give more and more days of empiric antibiotics, obviously that, your yield later on will be low. And there's only this small study of what if you don't give empiric antibiotics to patients who have diabetic foot infection? Are they going to have worse outcomes later? And this one did not, it was not statistically significant different. So we choose our empiric antibiotics based on usually severity, if they're very sick, obviously if they're in septic shock, especially if they're bacteremic, you want to treat them immediately. The question usually is, do you empirically treat MRSA? And I'll talk to you more about that later. But at the minimum, if you've already decided you're going to treat an infection, you have to cover the Staphylococcus species and the Streptococcus species. So at least that's what also in the guidelines, which I agree with. And if it's in a warm climate, usually you want to add Pseudomonas coverage. Not everyone needs Pseudomonas coverage. This one was a meta-analysis of 6 studies using MRSA nasal swab and diabetic foot infection using a Bayesian analysis modeling. The positive predictive not that great. The good thing about this is the negative predictive value is really high. So among for example, in this, if you look at the graph, if you have 15% prevalence of MRSA in your community, if you get a negative MRSA nasal swab, then it's about probably not, it's going to be negative. It's not going to be MRSA. Oral versus IV. So show of hands, is this new to you, or have you seen this more recently that oral antibiotics are being used for osteomyelitis? So this is something new. Traditionally, it's always been IV antibiotics, right? When someone has osteomyelitis, we always deploy. But this is the landmark trial, the first one, and Oviva, which randomized 1,000 patients with bone and joint infections. So comparing oral antibiotic, oral switch versus IV therapy, and they've showed that it's non-inferior. So as of right now, and most of the studies after this, like retrospective studies, smaller randomized trials, have shown the same result, that oral antibiotics are as effective as IV therapy. So in diabetic foot, you want to select oral agents with high bioavailability. Obviously, that implies that you would know which ones have high bioavailability. And it is usually, obviously, for the most stable patients. You don't want it has practical, in practice, it's easier to do for patients. So if ever you want to choose oral first before you want to go to IV. Treatment duration, they pretty much laid this out in the guidelines. So for example, if there's no resection at all, for example, a 4-foot osteomyelitis, we give up to 6 weeks of antibiotics. this is something new with this 2023 because usually, if they said if there's an amputation with a positive margin, something quote unquote was left behind, usually we treat that before the guidelines with like 6 weeks as well, because we count that as osteomyelitis, right? Not clean margin. But more recently, they said 3 weeks can be sufficient because of smaller trials and studies after that. And if it's fully resected, meaning way proximal to the area of infection, then a short course is sufficient. And obviously, if it's just soft tissue, you want to do like 1 week maybe. And these are the supporting trials. I think I'm running out of time. And you can see there that and that's a rule of thumb, right? The more aggressive you're with surgery, the less antibiotics you need. So you want to talk to the ID provider and say, okay, how much really is left behind? Like, I think that's what we really we want to hear when we're discussing this. How much is left behind? How confident are you that you got everything? How worried are you about this patient? Those things, so that we can tailor it, because it's not set in stone. Like, we can do 4 weeks, 5 weeks, 6 weeks, 7 weeks. It's not like, it's either 3 or 6. So you can talk to your ID providers. Some of the antibiotics alone, if we don't need surgery, forefoot osteomyelitis, no peripheral artery disease, and obviously if there's no exposed bone and it's limited tissue destruction, we can use antibiotics alone, medical therapy alone. You probably know this for sure, that if they have necrotizing infection, critical limb ischemia, severe infections, bacteremia maybe, you want to get to them as soon as possible. I won't go through this, but the guidance also kind of said this, that there's not a lot of evidence for these adjunctive therapies. I like what they said in the guidelines of like, you don't want to say cure to patients. And I think the oncologists are pretty good at this. They would say you're in remission, because none of our, and the previous lecturer to me was saying that we don't have a good way, there's no blood test, there's no even an MRI who would say, oh, this is the test of cure, meaning CRP is negative, MRI, so there's no way for us to promise them that they're cured. And as you know, like the previous lectures as well, that remission, the recurrence are so high, it comes back. So I think they're really good at saying that now we want to say they're in remission. Okay, I think that's pretty much it. This slides put things all together, and I'm happy to take questions.
You get a question Q&A session all day. So stay with us there. We visual there. We have tons of questions.
Yeah, we'll do all the questions afterward. Thank you, Dr. Tai. Next, we're excited to bring you Dr. Christopher Gross. He's a professor of orthopedic surgery and the director of foot and ankle division at the Medical University of South Carolina. He completed his fellowship at Duke University Medical Center and his residency at Rush University Medical Center after he graduated from Harvard Medical School. His practice focuses on complex ankle reconstruction, cartilage injuries, including end-stage ankle arthritis. Dr. Gross.
All right. Well, thank you, Alan, for allowing me to join you in South Dakota. This is exciting. And thank you to everyone that I've already learned from. And hopefully we can learn from each other in the future. So I'm not a computer guy. I'm just a guy who likes technology. And so as soon as artificial intelligence kind of crept into our world, I dove in, took an online course, and it forces you to, have like a final exam. And this was basically my final exam, is to try to come up with an idea of how I can use artificial intelligence to save my patients' limbs. And so what we do as surgeons on an everyday basis, we try to predict what's going to happen. We try to predict when the patient is going to need their next injection, when they're going to need their ankle replacement. But with diabetics and people with wounds or Charcot arthropathy, we have to figure out when they are going to lose the limb, and we want to prevent that. So we have our patient with all of these different issues. We have the surgeon with all of our knowledge, but there's a gap in that. You know, I try to remember what their wound looked like from last time. Did that picture adequately showcase it? You know, what bacteria did they grow 6 months ago? I don't remember all of that as best as I try. So we add a machine onto it. And what it does is it learns from thousands of patients. It doesn't fatigue, it always remembers, and it's going to build this into your clinical pipeline of, you know, you plug something in and it will tell you exactly what's going on. So these things are going to sharpen your judgment. So when you see a diabetic wound or a diabetic foot, you know, is this a local limb threat? Is it a toe threat? Is it a total limb threat? There are different types of patients, right? There's a local issue and then there's a systemic issue. So oftentimes the visible wound is the least complex part of the disease. It is a representation of something that's happening. Hopefully it's something that's local, something that can be treated. Taking off a toe is not that big of a deal, but taking off a limb is death. So the current staging systems are great. We've had a few excellent talks talking about the Wi-Fi staging system. It's very useful, but incomplete. And this is not by any means complete, but it adds a certain layer onto what we already know. So they do not answer what we're going to amputate. It doesn't tell us how much time we have before we have to amputate. What are the variables and risk factors that are driving this patient to lose their limb? And what can we do today? So we need 3 predictions and not just one, not just, hey, are they going to lose their limb? It's not a binary thing for us. It's what is their risk of needing an amputation, number 1. Number 2, what are we amputating? Number 3, at what time trajectory is this going to happen on? So this was the kind of website that we'd plug all of our data into. There's our prototype interface. You put in, you know, just patient information, basic demographics. It's not yet integrated into an EHR, but you know, it's an academic development tool. And then you kind of plot along the A1C and then albumin, and it outspits a number for you. We looked at 2,400 patients at MUSC in South Carolina. This is where diabetes is king. Like, we live in the Biscuit Belt in the South in America. There's a lot of burden here. So we have a lot of patients. 8 years was our window of looking at. We looked at 28 different predictors, and these are all things that we got from Epic. I had my college-age research assistants just pull the data from Epic. It's easy, and we can show you how to do it. We put them in the columns, and we gave it to our data engineers. We found out we had a really high amputation rate. So the model learned from things that we already look at every day. It just brought it all together and figured it out. So there is a different, and this is the technical part of it, which I'll slow down simply because the engineers had to engineer different things in order to tell us what was going on. So first off, they built a gatekeeper algorithm, which basically said, does this person need an amputation? Will they not need an amputation? And then there's a specialist architecture built on top of that. Is this a toe amputation, midfoot amputation, above the knee or below the knee? And then a Cox survivor analysis of over time, how long are they going to stay amputation free? So we wanted to make sure that there were more false positives, false negatives, right? So at worst, a false positive is going to increase resource use. Yes, I get them back into vascular sooner. They had, you know, more care from our team. We didn't want false negatives because we did not want to not capture losing a limb. So the gatekeeper model basically was able to tell us who needed the amputation. And the way that these things run is that it will look at the data for, like, say 6 years, and then look at the next 2 years of data and see if they actually predicted it. And, you know, 83% of the time it did. But the good thing is that we're able to identify critical limb loss. Like, maybe the model got a toe wrong here and there, but it did not miss cutting a leg off above the knee, and really not for a below the knee amputation. So we really need to care because there's a very different trajectory between a major and a minor amputation. And again, we need to know, time is of the essence. So what are we going to do with this information? How quickly are we going to do, something for this patient? So is this an immediate issue that we need urgent attention, long-term or near-term? So it helps us kind of view and predict in the future who is going to need what at what time. This is just a fancy, graph demonstrating the top drivers at amputation risk. And again, this is not me telling it. This is what it figured out for itself, which is what we already know. Okay, so we already know a history of ulceration, osteomyelitis. What was interesting to me was the albumin slope. So, declining health. And then they created a key distinction when we started to look at the model. So in the minor amputation pathway, again, this is a localized foot pathology. These patients had were overall not healthy, but not as unhealthy as their major amputation pattern. So in those with a major amputation pattern, those with BKAs or AKAs, that demonstrated a systemic decline of that patient, okay? Something is happening to them globally, body-wide, that is causing them to lose their limb. And the granularity is looking at what could be causing that. The great thing is the output of this model will tell us what are the modifiable risk factors, what needs to happen then. So after this data is spit out, and this is all algorithms and calculations, then a generative model on top of that will tell me, the clinician, 3 things that the patient can do right now and 3 things that I need to do right now for that patient. And you can set it up however much you want, but it does give you a kind of guideline and an instruction manual for that patient. And this can happen for every single patient that you see in your clinic. All right, so the large language model interpreted this and then will tell you how to decrease their risks over time. But really only it's great to have all this data, but prediction only matters if we do something about it. So again, you have this risk score, but what's important is the interpretation of that risk score. And that's where that kind of spit out at the end that the machine said, hey, these are your risk factors and do something about it. That is going to change our behavior. So I'm not selling you an AI. It's going to happen, join us or not. It was only our study. We would love collaborators, would absolutely love it. Again, we live in the South, or I live in the South, and my patients are Southern. So like getting a wide breadth of patients is going to be important. Calibrating this machine is going to be important. That's with more data. We started to add imaging to it as well. So keyed in with these patients, we added the radiographic reports. That is still ongoing. And then once we get the radiographic reports filed in there, then we're going to teach the machine what a Charcot foot looks like. And by looking, and eventually in a couple years' time, I'll be able to send it a Charcot X-ray, and tell them its demographics, and then really hone in on what I need to do. So, it's going to be a paper, great. But for me, what's important, why I did this, is to collaborate with all of you. I want to share data, and it's anonymized. Again, it's a bunch of tables that can be pulled out of Epic or an EHR system. We put it in the machine, we start calibrating it, we make it stronger. Once we have a strong predictive model, then we can start launching a prospective trial. What they're doing in England is incredible with, being able to reduce amputations by 30–40% over time. Imagine what we can do with a little bit of technology and collaborating all over the world. So we have our prospective trial, and then we can see in real world what we can do. And then we have our learning system, and it becomes an architecture for anyone that's involved in limb salvage to put data in and get information out. And again, we're not going to be overtaken by AI as surgeons. It just makes us better decision makers. Thank you.
Thanks, Chris. We didn't talk. Chris, can you stay here on the stage? I'll have you go all the speakers on the stage. So it's question and answer session. Chris is my Duke alumni, so he's always surprised me while I'm right. So he was trained at Harvard, and I was trained at Hopkins. So we have some a little bit of competition going on. We'll work with them. And so here also, Dr. Geno Tai, I abducted him at MSIS meeting a couple of years ago. I told him we have a mission to do. I need to do some work with you. And he's closer to me from Minneapolis. And I bother Dr. Hayes, Meredith, so we're so close in our office. I come down, bother her the most, but I find the best cooperation between MSK radiologist and orthopedic surgeon. That makes things so much easier. Communication is the key. So we start a question and answer session. Please ask your questions so we get this started. Any questions? Yes.
I'll perhaps ask Chris first, ask Chris to Chris. So thanks for the presentation. I was just wondering, in your model, I mean, we know for outcomes, we need patient factors and there are system factors. And most often than not, that is what really makes a big change. And the first question was over those 8 years or so that you did, whether there was any system changes that could be a factor, and whether you've modeled in access to service. Because, for example, a service cannot have maybe a vascular surgeon. You employ a brilliant vascular surgeon, and that same patient parameters in a different surgeon hands, you get a completely different outcome.
So I guess in that time of the
Okay. Sorry.
No, this will be fine. Yeah, thank you for that question. So actually, so I've been there since 2015. I hired a surgical podiatrist in 2019, and my partner Danny Scott, orthopedic surgeon, in 2020 to do limb salvage. In that time, we've lost the vascular surgeons that actually care about saving limbs. So I actually go outside of the hospital system to actually do that. Care, I think, has gotten worse and more fragmented, probably hastened by COVID and a lot of remote stuff. But I wouldn't say anything has necessarily improved since I've been there in terms of setting something up. The bandwidth is rather, I don't have a large enough bandwidth in order to, comprehensively take care of the diabetic patient, nor is there a program to take care of a diabetic patient in our hospital. Hence the need for, me and other surgeons to understand how you all do it so we can implement it and help save limbs.
Yes. Dr. Busui.
Yes.
I have one question to you, Chris, and then to Meredith, if that's okay, very quickly. Obviously, collaborating into such big training models is really great. How do we overcome data protection and confidentiality? What are the rules? How do we merge data in order to be able to really do multi-center studies?
Yeah, that's the great thing about the data engineers is that those that are well-versed in HIPAA, American HIPAA, and patient confidentiality know absolutely how to data share. So we started data sharing. We're starting a data sharing program with University of Florida to start to get their data as well. But it really is a matter of plug and play. I mean, these patients are completely de-identified, and it's certainly something that we can show you, your team, how to do. And again, I had college kids doing it. It's that simple. Like, there is such a process that it makes it's no difficulty at all.
Thank you. Can I just ask a question as a clinician to radiologists? How quickly can you get an MRI scan? So if you have a patient in clinic who requires assessment, what is the referral time between, obviously, referral to scan?
So at Sanford, I think our turnaround time is about 1 week or less. It's pretty darn fast. If you can give us a call, we fit you in. And at Sanford, we have doubled the amount of 3T scanners. So we kind of model ourselves as like a Mayo West. The more scanners we have, we even have scanners on mobile buses because we have rural areas that we need to get to. And so we have 3 mobile buses that have They have 1.5 Tesla MRs, but they've been upgraded software. So all these mobile buses go out and get all the rural areas. And so our turnaround time, I would say, is about a week. Would you agree?
Yeah. And I have her cell phone, so for me, it's 24/7. So, okay, so I have a question here. So it's a basic scenario, everybody has it. So this question will be direct to Dr. Tai and, Meredith and for Dr. Hayes. So always this scenario, you have a patient with acute charcot mistaken by infection when they go to the ER. So we saw those patients coming back and they were put on antibiotics and it's been a couple of weeks passing away or even a month, and then they already have the change. So the problem is, what's the most efficient way you think it's for imaging wise to sort out those patients? So we were told there is a simple test that we can do, elevation test, but I find it's not that easy. So a lot of patient has chronic venous stasis. A lot of patient has cellulitis on top of it. So what do you do the most efficient way to differentiate it from your perspective and from ID's perspective?
Actually, this unfortunately happens quite a lot. I think the answer, which I've done sometimes, the most effective way to know if it's infection or not is to stop antibiotics and to let it play out. Because like if that's the only way, right, for us to know really what the outcome will be. Unfortunately, once you've already started the ball rolling and where you're already coming in at like 2 weeks, 3 weeks time, I don't even know if like the nuclear medicine scans, even the PET scan, the sensitivity I believe goes down, and that's based on my understanding of endovascular infections, where like when you already pre-treated it, the sensitivity of the PET scans are already going down. So yeah, I'm not sure how to answer that question perfectly. Practically speaking, I would tell you what I do. If it's close to the end and, based on the multidisciplinary discussion, it's the pre-test probability is high, I just complete it empirically and I stop. Even if it's, based on our, review, if it's low, then I stop. I hope that answered the practical question.
So you're trying to ask, like, basically they've been in the ER, they had the cellulitis, they've started their antibiotics.
Yeah.
But they still have an ulcer.
Yeah.
So how do you differentiate that? It's still, in my radiology, that's going to be the MRI, because the MRI is going to show you that algorithm of if you have the marrow replacement on the T1, right? So you got localized marrow replacement and marrow edema that's adjacent to the ulcer. And you have the ulcer that tracks down to the bone, despite whether they've been on antibiotics, they had a biopsy, whether it was negative or positive. It's going to be the MRI with the contrast. So if that answers that question.
Thank you.
Yep.
Yes. Yes. Dr. Sanders.
I'm a long-standing institution. That's why I talk, but also many times all of our things of the last few months, there was new literature that was more and more talked about administration, intrahospital administration, is now being not legal places of black things that the bank gives in the as well as other local applications rather than meetings. Any comments on that? Seems to be that experience in the face.
Yeah, good question. I do have a comment on that. The question is, what can I say about local antibiotics, bone cement, local delivery? There's a great trial on this called Solario trial, which has already finished enrolling, and actually they've sent out their they've already presented their top line results so Solario trial is comparing bone cement, local antibiotics, plus 7 days of systemic antibiotics. That's one arm. The other arm is just 6 weeks of systemic antibiotics, no local antibiotics, and they're non-inferior. So you can see that in the future, they're going to publish this for sure, so that the systemic part is going to be shorter and shorter and shorter, and then we're going to go to the local administration. And that, I think that trial, if you look at the clinicaltrials.gov, it's mostly diabetic foot and fracture-related infections. But they've also enrolled people with PJI, like prosthetic joint infections.
Any other questions? Yes, please.
Yeah, the Solario study should be published in New England Journal of Medicine in the next months.
Yeah.
That's what we've been told for 2 months.
Yes. So that brings us, so Dr. Sanders is very accurate from the recent trend. So IV versus oral, and the one stage over like a 2-stage revisions in surgery, and also topical use. So there doesn't seem to be enough literatures on topical use, and we have been using tons in and out. And I clinically, anecdotally, and some patients are doing really well. And we have intraosseous using of antibiotics. Well, do you see any issues with stewardship of antibiotics as we're using more and more local vancomycin, gentamicin, and especially the new trend that we're using? We have been very, so we are very excited about that. But, whether that in 5 years, 10 years, and say you guys are doing stupid thing, create a huge problem. What do you think?
Two things. For treatment, I think it's worth it to try because it's treating infection. Preventing infection is a completely different ballgame, right? So, for example, prevention in primary arthroplasty, and then you're putting something in, it's like that's, and we know because the percentage is very low, the number needed to reach thousands before you prevent one. So I think in that part, I would say I have concerns. And to be honest, it has not panned out, like for prevention. For treatment, there's more evidence, I would say. And actually, going back to the Solario trial, Dr. McNally and their team and Oxford, is actually the main reason why they want to do that is to reduce exposure, systemic antibiotic exposure, because that arm has a shorter duration. It's just 7 days for osteomyelitis and implant infection. So one of the, in reality, it should shorten exposure.
Great. So I'm sure we still have a lot of questions unanswered, and really appreciate everybody's. And so we continue. We will have a little break. So a little bit of housekeeping. So later we're going to do a group pictures. So everybody, we do a group picture at the registration area, and then we continue our last session. And after our last session, we have another question and answer sessions for today. And then we have a business meeting for our society, inauguration of our 2 societies today. And then around 5 or 5:30, and then we go to across the street, the barn, we have a reception. We hope we see everybody here. So Joe, are we going to the group picture right now?
I would say if we have all the attendees, we can get as many of them in front of the Sanford sign, but I know that a couple of our speakers have stepped out.
Oh, they're stepping out. So we do it after the next session then.
Yeah, let's do this.
All right.
But
great.
Feel free to go through the vendor space.
Sure. Yes, thank you very much, everybody. All right. Okay, all right. So the last stretch of today. So we get over our last session of today. So we have Dr. Sicco talk on one of the most important. So all factors are important in diabetic care. And we all know how important those patients get to the right shoes. and what's the evidence of choosing the right shoes or orthotics. We have one of the best expert from Netherlands, Dr. Bus. So we got it started.
Hello, my name is Sicco Bus, and I'm a professor of clinical biomechanics at the Amsterdam University Medical Center in the Netherlands. And today I will speak on the evidence and the rationales of the use of footwear or orthotics in diabetic foot disease and what the recommendations are in the International Working Group on the Diabetic Foot Guidelines. These are my disclosures, so I have different roles in the International Working Group on the Diabetic Foot, and I'm also chair of the organizing committee of the International Symposium on the Diabetic Foot held in 2027. And I have different research funding from Europe, national funding, non-commercial funding. So when we look at how foot ulcers develop in diabetes, the vast majority of foot ulcers have a mechanical pathway where the different neuropathies work together to cause foot deformities and biomechanical abnormalities, which are not felt in terms of pressure and pain due to the sensory neuropathy and also dry skin due to the autonomic neuropathy. And then three mechanical pathways can occur where there's continuous stress of constant low pressure damage, for example, from an ill-fitting shoe, or repetitive stress with moderately increased abnormal pressures during weight bearing, which then go on to form first callus and then a foot ulcer underneath that callus, or a high stress from direct mechanical trauma. Here you see a couple of examples where in the middle there are 3D pictures of the plantar pressure under the barefoot walking, where the pink and the red peaks are the high pressure regions and correspond to the locations where the foot ulcers are present. So it's the high pressures in combination with the sensory neuropathy that cause most of these foot ulcers. So high plantar pressures have been identified as a significant risk factor for diabetic foot ulcer development. But if you would purely look at the sensitivity and the specificity of barefoot pressures, then these are quite low. And that is because, of course, barefoot pressure is a component, but patients also wear shoes and are maybe active or maybe less active, and that also plays a role. And we've been able to look at this in a little bit more detail, where if you look at the cumulative plantar tissue stress that is loading on the foot, so the total load on the foot, and you divide that with if patients walk barefoot or they wear shoes or whether they're standing or walking, then the walking in the shoe only contributes 13% of the total plantar tissue stress on the foot. A much larger component is caused by walking barefoot, where the number of steps may be fewer than when walking with shoes on, but because the pressures are much higher, the contribution to the cumulative plantar stress is larger. Also, looking at standing, patients tend to stand twice as long during the day compared to walking, and the in-shoe standing was 16% of the contribution to the cumulative plantar tissue stress, but then barefoot standing was 31%. So if you look at this all together, 70% of the total load applied on the foot in these high-risk patients are explained by being barefoot and not wearing appropriate shoes. So this also stresses that the behavioral part of the patient is a very important one in terms of explaining what the load on the foot is. This study also showed that this cumulative plantar tissue stress wasn't a directly predicting factor for foot ulcer development, but it was significantly associated with the development of pre-ulcers. And we know from pre-ulcers, and confirmed that also in this study, that they are strong predictors of plantar foot ulceration. We also found that walking speed strongly predicts plantar foot ulceration, where a lower walking speed is predictive of foot ulcer development, where we think that walking speed may be a marker for a vulnerable foot and patient, and therefore a factor in ulcer development. So now, knowing that these pressures are high, how do we offload these pressures? Well, over the past several decades, many different interventions have been developed and are used and also studied, ranging from different casting methods, both knee high or lower, maybe ankle high, different walker conditions that are knee high or ankle or tibia high, which can be made non-removable to improve the adherence. Also, different footwear conditions can be used to offload the foot, and also surgical interventions. To give an example of how effective a non-surgical treatment by total contact cast can be, here's an example of a patient with a plantar foot ulcer underneath the right hallux, developed while wearing already custom-made footwear, which you see on the lower left corner. And this patient was treated with a total contact cast on the right foot, where these images of the plantar pressure demonstrate that the total contact cast is extremely effective in relieving these high-risk pressure regions and distributing these pressures to other regions of the foot. So you see that actually over the whole foot, the peak pressures are lower, and that is because about 30% of the total load on the foot is transferred to the lower leg because of the knee-high total contact cast device, and further offloading of the forefoot is achieved by molding the casting material when still moldable and applying pressure to more proximal regions in order to offload distal regions. Another way to offload the forefoot is by using a rocker outsole configuration in a shoe, or maybe even a negative heel, of which there's an example shown here where the forefoot is actually at a higher level than the heel, which causes a lot of these pressures on the forefoot to transfer more proximally to the midfoot and to the heel, which is shown on the right hand side in these by these arrows. So therefore, as the pressure picture shows on the right foot, relieving the pressure underneath the forefoot, building up the pressure underneath the midfoot, but not to levels that are increasing the risk for ulcers there, and also some pressure going to the rear foot region. Also, different design elements in the shoe can cause pressure relief, and quite effectively. On the left, a rocker outsole configuration in a shoe is shown, where studies show that between about 30 and 50% of the forefoot pressure, the metatarsal head plantar pressure, can be relieved by such a construction element in the shoe. Custom-made insoles, increasing the total contact, the contact area underneath the foot, and providing pressure relief underneath the medial arch support, and also proximal to the metatarsal head region, are effective in relieving pressure, which you see in the center of the slide. And a different cover material of the insole can have a pressure relieving effect of about 10 to 15%, and also increasing the rigidity of the outsole or midsole of the shoe, where causing metatarsal phalangeal joint to be limited in its motion, and with that pressure relief can be achieved underneath the forefoot region. This shows an example of the effect of a custom-made insert compared to just a regular flat insert, where you see the pressure distribution pictures on the right-hand side for the custom-made insole, where the high pressure underneath the medial part of the forefoot, so the first metatarsal head, are relieved by such a custom-made insert because of the medial arch support, and further total contact being applied, and more pressure relief underneath the forefoot by building up the pressure underneath the proximal region. So transferring the load to the midfoot, but again, not to pressure levels that are by itself increasing the risk of foot ulceration, and also seeing here that with a cupping of the heel, pressure relief can be achieved underneath the rear foot. Now, these are all non-surgical interventions, but there's also studies that show that surgical interventions can be effective in relieving pressure underneath specific regions. For example, digital flexor tenotomy, which is a commonly applied intervention for mainly for lesser toes where apex ulcers or pre-ulcers are present. And on the right-hand side, you see what the effect is in a patient who had pressure measurement underneath the foot, barefoot pressure measurement before the operation, with increased and quite high plantar pressure shown by the red arrow underneath the second toe, and then after the tenotomy with a straightening of the toe as an effect, we see that the peak pressure there is completely disappeared. And a study showed that in 50 toes in 19 feet of 14 patients, the mean peak pressure of 430 kilopascals was reduced very effectively to only 150 kilopascals. So a very effective way of relieving pressure underneath these lesser toes. So the International Working Group on the Diabetic Foot is tasked with writing guidelines on different aspects of diabetic foot disease that are shown here on the right, and every 4 years updates these different guidelines on peripheral artery disease, infection, classification, prevention, etc. Also on offloading, there's a guideline that has been developed since 2007. And as I said, every 4 years is updated. And this is the offloading pathway by which the offloading guideline is organized, where in the red you see a person with diabetes with neuropathy and a foot ulcer. That's the starting point, and based on where the location of the foot ulcer is, for example, the plantar forefoot or the midfoot ulcer, and whether there's an infection or ischemia present, so a complication of the foot within the foot ulcer or not. The green boxes show the recommendations for such ulcers. So if we take the most common, at least not foot ulcer, but looking at where most evidence is available for a plantar forefoot or midfoot ulcer where no infection or ischemia is present, the first choice treatment and recommendation is to use a non-removable knee-high offloading device. There may be contraindications or patients not tolerating such a device, and then the recommendation is to consider using a removable knee-high or ankle-high offloading device, and encouraging the patients to wear the device, because we know that if not wearing the device, the efficacy of healing the foot ulcer will be less. If these devices are not available, then the recommendation is to consider using felted foam with appropriately fitting footwear. So never just felted foam by itself, but also always in combination with a proper shoe. The recommendation is regarding lesser toes and foot ulcers present there, secondary to a flexible toe deformity. The first choice treatment is actually to use a digital flexor tenotomy operation. If these plantar forefoot ulcers do not heal, if they fail to heal, then the recommendation is to also consider surgical intervention, such as Achilles tendon lengthening or metatarsal head resections or joint arthroplasties. The forefoot and midfoot ulcers can also be infected or ischemic, and when there's mild or infection or ischemia present, still a non-removable knee-high offloading device can be used. If there both mild infection and mild ischemia present, then the recommendation is to consider using a removable knee-high and ankle-high offloading device. And if it's more moderate or severe, then first the infection or the ischemia has to be addressed before the offloading is taking place. But still, offloading plays an important role here for healing these foot ulcers. Plantar heel ulcers, the recommendation is to consider a non-removable knee-high offloading device, and a non-plantar ulcer to, specifically based on where the location of the foot ulcer is, to use footwear modifications, toe spacers or orthoses. And a new recommendation in the 2023 guideline is if there's, for treatment of an ulcer, an offloading device is used, consider using a shoe lift on the contralateral limb to improve comfort and balance while walking with the device. When it regards the prevention of foot ulcers, an important key element is ensuring the routine wearing of appropriate footwear. And this is based on several trials that have been done across the globe, so in the US and in the Netherlands and also in Spain, showing that when data-driven approaches are being used to design and develop optimally reducing plantar pressure reducing footwear, and the footwear is worn as recommended, then a significant reduction in the risk of foot ulcer recurrence can be achieved. So these trials have been very informative for the development of the guideline recommendation, where it says that in a person with diabetes who is at risk of foot ulceration and has gone through an episode of plantar foot ulceration, the recommendation is to prescribe therapeutic footwear that has a demonstrated plantar pressure relieving effect during walking, so to help prevent a recurrent plantar foot ulcer. But it's very important to encourage the person to consistently wear this prescribed footwear. And we also have some recommendations and some indications on what we mean with a demonstrated plantar pressure relieving effect. So in summary, regarding the footwear approach to the healing, but mainly for the prevention of foot ulcers, the state-of-the-art approach now is one that uses a systematic approach, so certain design rules for how to create a properly offloading shoe. It uses science as a basis for the design, as well as I've presented many of the pressure relieving effects of different design elements within the shoe. It uses data-driven approaches, so for example, in-shoe plantar pressure measurement as an evaluation of the footwear, but also to use as a guidance to modify the shoe. And it's evidence-based, based on the multiple trials that have been done, showing that the approach of using such footwear is effective in reducing the risk of foot ulcer recurrence.
Next, we're pleased to present Dr. Armin Koller, who will be presenting digitally. Dr. Koller is an orthopedic surgeon who specializes in technical orthopedics, diabetic foot reconstruction, and complex lower limb disorders. He serves as Chief Division of Technical Orthopedics and Co-Chief of the Interdisciplinary Diabetic Foot Center at Matthias Hospital in Rainy, Germany.
Thank you, Dr. Jan, for giving me the opportunity to share my very personal thoughts on diabetic foot reconstruction. I have no conflict of interest to declare, and I start with a little detour. In this case, it's a hallux rigidus, so a stiff joint causing an apical ulcer at the first toe. Therapy in this case is to perform resection arthroplasty with the goal to restore mobility of the joint in order to decrease pressure around the toe. If we come to ulcer in combination or caused by Charcot neuroarthropathy, the usual recommendation is to perform ankle fusion. And I just want to point out that, of course, we need stability in the coronal plane, but do we also need a completely rigid joint in the sagittal plane? And that's the question I want to follow during my presentation. Coming to the International Working Group on the Diabetic Foot recommendations for therapy of Charcot neuroarthropathy, you will also find arthrodesis amongst the recommendations, with the goal to redistribute pressure throughout the foot. And once more, my question is an arthrodesis really an ideal tool to redistribute pressure through the foot? This is a biomechanical study based on a finite element calculation for the distribution of von Mises stress and also peak pressure in a foot model. And the result was that, peak plantar pressure was increased and the center of pressure moved anteriorly after performing an ankle arthrodesis. As you can see here on the illustration, with the left foot is the normal situation, the right foot is always ankle arthrodesis, and then here you have first peak, so with heel contact, and this is the second peak, so with push off, and you see a considerable increase of peak pressure around the central metatarsal bones. In an analogy, this study, a single case study on a rheumatoid foot, was an observation made by the surgeon that excessive load was applied to the forefoot during push-off by the toes, resulting in a stress fracture. And his conclusion was that surgeons should choose a surgery that preserves ankle motion to decrease the rate of adjacent joint degeneration in patients with rheumatoid arthritis. But this, to my mind, conclusion is completely transferable to the situation with Charcot foot. Long-term review of literature also shows that arthritis of adjacent joints is a common finding due to increased mechanical stress. This is an additional problem because increased mechanical stress is usually considered to be a likely causative factor of CNO. So yes, with an ankle arthrodesis, we solve one problem, but we might start with another problem. The situation is different in the midfoot. The midfoot, to my mind, definitely needs a solid arthrodesis, but not necessarily a superconstruct. This is an example of a Charcot foot type 2, according to the classification of Sanders and Friedberg, and Lisfranc arthrodesis with an external fixator has been performed. Follow-up treatment is necessary. You can see here that, as usually, you have an ulcer at the convexity of the deformity, you see the fixator, and you see the final result. This is a solid arthrodesis, but only the joints that are essential for long-term stability are fused and not beaming of the entire foot, which is not necessary. But to make this point again, in a case of midfoot Charcot, a solid arthrodesis is necessary, but the ankle joint, of course, is still preserved. So that problem with the bone resorption challenging the surgeon to come to superconstruct techniques is in my practice not necessary. So the external fixator can be regarded as a superconstruct, and the problem with bone resorption is not caused by insufficient metal supply in the foot. It's a problem of neuropathy and the influence on bone healing and fracture healing, so that the time of post-operative bracing has to be long enough. As a rule of thumb, at least 3 months in case of a midfoot Charcot, and 6 months and even more in case of a Charcot of the ankle joint. And so we have to draw the right conclusions from neuropathy and bone healing. Seems to be a little bit, what's this? Temperature? Concrete? Yes. Temperature has an influence on concrete to develop strength. So if it's too cold, it takes longer. But no one would say, yeah, we just need more steel in the bridge. We just need more temperature. In case of Charcot neuropathy, the problem is time, because with neuropathy, bone requires approximately twice the time for fracture healing compared to the situation without neuropathy. So follow-up treatment is essential to bring the foot to healing. So it's time and not superconstructs. We have to break that vicious circle. Surgery followed by inadequate offloading, leads to a new inflammation and osteolysis to fracture dislocation, deformity, leading to surgery again. And so this has to be interrupted or avoided by adequate offloading. This now, I'm coming to ankle arthrodesis, is of course a situation where ankle arthrodesis cannot be avoided if it is even achievable. So this was a lady with Charcot type 4 with nearly dissolved talus and also a concomitant Pseudomonas infection. And in her case, we performed ankle arthrodesis with the help of an external fixator. And this was the final result. Of course, now we do not have any mobility, but in this case, I'm also quite happy that fusion or stability could be achieved at all. This is a different situation. This is a type 4 Charcot with a tibial cyst with a massive valgus at the of the calcaneus, leading to fibular stress fracture, and where operation is necessary. But in her case, you see the CT scans here, we did not perform a classical ankle arthrodesis, but more realignment arthrodesis of the ankle joint. So you can see the frame. We reshaped the ankle mortise. And this was the outcome after nearly 2 years with a completely realigned joint with enough stability in the coronal plane, but also some remaining mobility in the sagittal plane. So the concepts can be shown here a little bit more in detail. Another case with a floating talus here, complete instability around the ankle joint. And what we did was this. So the talus or the remnants had to be removed. There was no real ankle mortise any longer. So we reshaped this, shortened the tip of the fibula. The calcaneus was placed into the new ankle mortise, left there in place for about 8 weeks. Follow-up treatment was casting for a few days after removal of the frame, followed by an custom-made ankle foot orthosis that the lady had to wear for about 6 months. And this was the final result. Here you can see after removal of the frame, the foot in coronal and sagittal position on X-ray. And this is outcome after 16 months. So you see the calcaneus in the reshaped, deepened ankle mortise. And you can see the clinical results here. The woman is standing. Yes, the foot is a little bit shorter, but it is still mobile. Hoping that it works. Yes. So it's stable in the coronal plane and it's still flexible in the sagittal plane. So, in summary, progressive bone deformity and bone resorption are a temporary phenomena that can be counteracted by doubling the duration of postoperative bracing. And so for me, the concept of superconstructs is not always necessary. So, and on the other way around, the presence of metal implants in the foot makes revision surgery considerably more difficult. So there should be done a little bit more investigations in the, let's say, advantages of external fixation surgery over bulky metal implants. Polyneuropathy is both part of the problem and part of the solution, allowing for, maybe even requiring, surgical techniques that deviate from traditional standard. And to my personal opinion, to my mind, ankle arthroplasty may offer advantages over ankle arthrodesis in case of a Charcot neuroarthropathy. So thank you for your attention.
Our next remote speaker will be Dr. Alex Wee. Alex Wee is an orthopedic and trauma consultant surgeon. He specializes in foot and ankle surgery with a focus on diabetic foot infection, Charcot reconstruction, neurological deformities, and complex hindfoot conditions.
Hey, morning, everyone. I'm talking to you from England. I'm sorry I can't make it today at your first ever face-to-face meeting. I'm going to speak about prophylactic surgery for diabetic feet. My name is Alex Wee. I'm the orthopedic clinical lead for diabetic foot surgery at Frimley Park Hospital. We are a district general hospital with approximately 750 beds, plus or minus a few. We have a vascular hub, a regional vascular hub, which means all the vascular cases come to us for reconstruction, revascularization. And additionally, we also accept renal dialysis patients. So as you can expect, we see a lot of these challenging diabetic foot cases in our center. I head a unit of two other foot and ankle surgeons who have an interest in this type of surgery, alongside my vascular hub colleagues, endocrinologists, microbiologists. We also have a plastic surgeon on board the team, as well as all the other allied health professionals, nurses, podiatrists, orthotists, etc. So first of all, why do we do this sort of surgery? It is often better to prevent a problem from developing and that problem leading on to difficult and challenging complications. The complications such as infection, collapse, etc., deformity, they all increase the complexity of subsequent salvage surgery or reconstruction. So the function of offloading surgery is essentially to reduce foot pressures, remove the prominences, to downgrade the Charcot process, and stop further problems from arising. When do you time this sort of surgery? Essentially, when you identify they are neuropathic and when there is evidence of overload in the foot or subsequent deformity, or even both. And the idea is to convince the patient that a small procedure now will save a bigger problem later. So today I'm going to talk a little bit about the arches and the anatomy, how the foot loads and fails, where the forces and the pressures are distributed in normal and abnormal feet, Charcot and secondary mechanical changes, and I'll go through some offloading surgical techniques. The arch mechanics we're all familiar with. It relies on the keystone with sloping sides. It fits into the apex of the arch. It slides down, pushing the forces outwards into the voussoirs, the supporting arch stones, and down vertically through the vertical supports and out through the abutments of the foot. And that is how an arch transmits force. And the arches in the foot we are all familiar with. The transverse arch, the intermediate cuneiform, is the keystone. The talus is the keystone for the medial longitudinal arch. And the mid-tarsal complex, with the cuboid at the very base of that arch, comprises the keystone of the lateral longitudinal arch. And together, the three arches combine to form a vault which supports the weight of the body transmitted downwards via the tibia into the talus. The bones exert a lateral force into the ground, and counter pressure from the ground reaction force. We're familiar with the function with the tendons and the plantar fascia. These are soft tissue structures which hold and allow shape change of the arches throughout the gait cycle, and it allows transmission of force during the gait cycle from the hind to the forefoot. And here you are. These are the structures of the soft tissues. The arch fails essentially through excessive overload. These diabetic patients are heavy. It leads to possible crushing on the convex, the dorsal surface of the arch, creating a hinge. The hinge then functions in its the hinge then functions to create cracking on the underside, on the tension side, and when cracking occurs on the tension side, the arch fails and there's possible snap through and breaking and collapse of the arch. So this diagram shows that the progressive equinus force of a tight Achilles complex in combination with dorsiflexion moment on the forefoot with weight bearing leads to increased forefoot pressure. The action of tibialis anterior accentuates the deformity, predisposing the midfoot to escape dorsally. The talus moves vertically. You lose Meary's angle. You lose your calcaneal pitch. You start developing a midfoot rocker bottom. The diagram here shows arch failure as I just explained in the previous slide. The loss of the calcaneal pitch, the dorsal crushing and accentuation of the forefoot moment, the dorsal forefoot moment as the midfoot is lifted upwards with the tibialis anterior action. And it all creates swelling, redness, collapse, and deformity. The Peter Barrow graph will show you areas of increased focal plantar pressure, and it's used to identify pressure distribution, and you can see where the pressure happens in the medial collapse with the medial rocker bottom, and also with hindfoot equinus. You can see the accumulation of pressure in the forefoot. And here we have transverse arch collapse in both feet, predominantly more noticeable on the X-ray on the left, as well as lateral longitudinal arch collapse and failure of the lateral plantar calcaneal cuboid ligaments. This leads to cuboid drop, as you can see in the bottom two slides. The strategy of offloading is to neutralize the force, to remove points of skin attrition where there is excessive bony contact and force. So moving on to where the ulcers occur, the ulcer at the medial edge of the big toe, often associated with a flat foot deformity, a pronation of the hallux at the MTP joint. You have an ulcer on the medial edge of the IP joint. This is caused by tightness of the medial band of the plantar fascia, with callosity presenting as the earliest sign. Ulceration probing down to bone is commonly associated with underlying osteomyelitis. Treatment in clinic can be achieved by releasing the medial band of the plantar fascia. You can do this for a flexible big toe with a callosity. If there's an ulcer with underlying osteomyelitis, one needs to consider additional procedures. It can be done fairly simply by dorsiflexing the big toe, tensioning the medial band of the plantar fascia and releasing it with a white needle. You can often feel the click similar to a needle fasciotomy for a Dupuytren's contracture in the hand. When it probes down to bone, an MRI is required to assess the extent of the osteomyelitis, whether it affects the MTP joint and the head of the metatarsal. And in this case, you'd have to excise the infected bone, release the medial band of plantar fascia. I would treat the void with Ceramide G or V and give them oral antibiotics for 2 weeks. You can temporarily stabilize with a 2 mil K wire across the first ray. An ulcer under the head of the first metatarsal is often seen in a cavus type foot caused by the overpowering and imbalance of peroneus longus, and they can be divided into flexible or rigid deformities. For a flexible deformity, this can be treated with a longus to brevis tenodesis, as well as supportive orthotics to correct and address the varus deformity. If it's rigid, surgical offloading can assist, and this can be augmented with a metatarsal osteotomy. This can be done either as an open or an MIS procedure. I would normally favor an open dorsal closing wedge metatarsal osteotomy. The ulcer is debrided. The sesamoids can be excised, and the area of infection can be treated with Cerament G or V. Forefoot ulcers underneath the head of the big toe, second ray. This is driven by hindfoot equinus causing forefoot overloading. The motor neuropathy causes a contraction of the gastrosoleus complex. There is non-enzymatic glycosylation of type 1 collagen of the tendo Achilles. It results in a hindfoot equinus. You note the decrease in calcaneal pitch on the lateral weight-bearing X-rays, and as a result, the load gets transmitted unfavorably to the forefoot, creating increased pressure and plantar pressures and subsequent ulceration. You develop a callosity under the metatarsal head, which breaks down when walking in normal shoes, and eventual inoculation of the deeper tissues and osteomyelitis. So approximately over 20 years ago, total contact casting was found to improve outcomes. Muller's group found that TCC alone led to 88% of ulcer healing at around 41 days, with a high recurrence rate. 59% of them came back around 7 months, and 81 came back at 2 years. If you add Achilles lengthening, 100% of ulcers healed around 58 days. 100% of ulcers healed around 58 days. There was a recurrence of 15% at 7 months and a 38% recurrence at 2 years. So significantly better outcomes. My colleague in Basildon, Madhu Tiruvedila, has established a 2-stage treatment. He undertakes tendo Achilles lengthening in the outpatient setting. And for those with persistent or recurrent ulcers, there's a second stage where he undertakes a dorsal closing wedge osteotomy in the proximal metatarsal, and this is done in theaters under an anesthetic. He's published his outcomes in FAI 3 years ago. So these are classical cases. These are slides he kindly sent me. He undertook surgery for these cases with tendo Achilles lengthening. The gastrosoleus complex can also be released by addressing the tight posterior medial gastrocnemius aponeurosis. The medial side is addressed because it's thicker than in cross-sectional area than the lateral side. Alternatively, a Hope triple hemisection can be used if the contracture is very profound, and this can be addressed simply through 3 percutaneous incisions. I do these in theatre. I find the contracture quite difficult to overcome in clinic with a needle. The skin is often stiff, hardened, scaly, so I try and do these in under aseptic conditions in theatre. So Over 20 years ago, Armstrong and Brodsky's group identified with neuropaths, the peak plantar pressures during the gait cycle can be as high as 100 Newton centimeters squared, and in a normal non-neuropathic foot, it is less than half of that, at 45 Newton centimeters squared. Following Achilles lengthening for neuropaths, it drops by almost 34%, down to 63 Newton centimeters squared at around 2 months from surgery. Madhu has confirmed this with his most recent paper in 2023. For his group, for Madhu's group, he did the procedure for 146 feet, tender Achilles lengthening and total contact plaster with a follow-up of a year. He found that 96% of ulcers healed within 10 weeks. 12 feet recurred, showed recurrent ulcers or failed to heal. And for those 12 feet, he undertook metatarsal osteotomies and they all healed. There was an improvement in calcaneal pitch of an average of 6 degrees. He also noted the cuboid height improved in 3 out of 4. So he managed to downgrade the severity of the Charcot process as well. So we're all familiar with how claw toes develop. There's a change in axis of pull between the intrinsics and an imbalance with the FDL tendon. As a result, the fat pad subluxus moves out of position. You're then walking on the metatarsal head with an increased forefoot pressure, and it leads to ulceration on the overloaded skin. This can be addressed fairly straightforwardly with a percutaneous needle tenotomy. This is a procedure that can be easily done in clinic with a white needle. The patients are often neuropathic. As long as they're not taking anticoagulation, it can be done safely without alarming levels of bleeding. Anderson looked at his group of 81 feet on whom he undertook 104 tenotomies. Just around 2/3 were male with an average age of 65 years old. A third of them had type 1 diabetes. 36 tenotomies were done for an ulcer on the foot. 34 tenotomies, 34 feet healed in an average time of 28 days. The 84 prophylactic tenotomies, 6 developed an ulcer. There were no serious complications, infections, or amputations recorded. Moving on to Charcot-exostectomies, knocking off the bony bump, which can predispose to ulceration or pressure buildup on the skin. It's fairly easily done. Often the skin is very stiff. You need something heavier than a self-retainer to retract the skin. I use a laminar spreader. I apply either a saw or a sharp osteotome and knock the bump off. You can either go through the ulcer or to one side of the ulcer, as I have done on this occasion. The results of exostectomy historically has been mixed, and these various authors have shown results varying between 50 to 75%. Yamanini looked at the literature 6 years ago, and he reviewed it, and he found that in whole, 96% of patients healed within a month of bony offloading with exostectomy, compared to just around 2/3 healing within 3 months of non-surgical offloading, concluding that it was a worthwhile enterprise to knock the bony bump off. So really, what have you learned in the last 15 minutes, or what have I reminded everyone of? Hopefully you'll be more familiar with the arch mechanics and the anatomy of the foot, how the soft tissues and tendons are essential in the supporting of the arches and failure of the arches, and the modes of failure, and what can happen radiologically to the foot. We've been through some offloading surgical techniques for flexible and rigid deformities that involve a mix of soft tissue releases and bony cuts and osteotomies, as well as exostectomies. And ultimately, prophylactic surgery is easier, cheaper, and prevents problems. And the key word in the NHS is cheaper. We are restrained by budget. We're looking for quick wins, quick, easy wins, and prophylactic surgery can provide this for this very challenging group of patients. And feet are worth saving because they're not just for walking. Thank you very much.
Great talk, great experiences. I remember I met with Alex years ago in London. And then I said, I want to come over and visit you. So I went to his place and I witnessed how he operated. Those surgeries actually, it's very intimidating when you first detect those patients. Those are sick patients and have multiple medical issues. But then when I started to follow those principles, I learned from King's College, King's Group, I learned from Alex, I learned from Italian groups. Actually, those are so satisfying. Those patients responded really well. So it's exceeding my expectation. Well, we always have some questions like this question, if anybody in the audience have experiences there. So like the autonomy, flexor autonomy. So I've tried it both ways. So the MIS group has been going on. They're using beaver blades, and we differentiated the FDB and FDL. You do it in different levels. But for diabetic patients, all those meetings we talk about, I went to the diabetic meeting other than the MIFS. You guys do it at the level at the base of the metatarsal, which is taking both off. So there is no comparison of those two. So those are interesting that we communicate, different ways of we doing it. So before we go into any deeper, I have a couple of announcements for the rest of the day. So what we're gonna do is after this, we have announcing exciting inauguration of 2 sibling societies along with our Rushmore. One is International Foot and Ankle Elizarov Society, because we went all over the world, all over the country. There are limb lengthening conferences, there are deformity correction conferences. There is no specific foot ankle Elizarov. So we grasped with this chance, me and Dr. Panchabavi, we are co-founder of the societies, and we also established the International Society of TTT Surgery. So let's have Dr. Panchabavi, give his insights of those society, what our vision and how it's going to develop. And after this session, we will have a question and answer on preventions. We have Dr. Busui coming back, and we have, Dr. Lawrence Lavery, and we ask about the prevention aspect. And that will conclude the didactic portion. And then we have encouraged you still visiting the vendors. Then around 5 or 5:30, we have a reception at the barn. So I like to using orthopedic terms when you are out of the front door. So the barn is 30-degree lateral to you. So not the opposite one. So that's a foundation, but 30 to 45-degree lateral to your direction, that's the barn. And walking distance, if you have any need to transport, we have transport available. Okay, we have Dr.
Thank you. Amazing job, Alan. You've been an amazing, thing to put together different specialities. Honestly, I was talking to folks here, so we all, operate in our own silos, right? We are all in our own echo chambers, and we do. I'm a surgeon. I only look at the surgery point of view. I don't do much interaction with other folks. So I've learned so much already. Learning from the MRI folks, for example. There's so many new modalities, infection, and so on and so forth, offloading and so on. So it's a great idea to have a multidisciplinary meeting, something like King's College folks are doing, like multidisciplinary teams. So we should have multidisciplinary meetings on these things. So coming to these new societies, Alan really mentioned that, we go to these external fixator meetings, and they're mostly focused on everything else. but we need a dedicated society for the use of Iluzorov for Charcot arthropathy management. You know, you heard Armin talk about his use of Iluzorov techniques to manage Charcot neuroarthropathic conditions. So again, how many of you folks heard of TTT here? TTT, only a few, right? I mean, a few years ago, I had no clue. You know, when I first went to this, heard about this TTT, what the hell are you doing? Why are you breaking a bone so far away from the problem? I thought it was a crazy idea. But then when you see the results, you start to believe it. And I actually adopted this in my own practice, and I thought, well, there's so much more to learn about TTT. So Alan and I thought, okay, we should have a separate society, and we would love for you folks, you know, whether you are doing the TTT or not, whether you're thinking about it or not, whether you think that there could be something more to be done or not, I would want both Alan and I would love to have you guys join this society, because this will be a focused society on TTT, and there will be another society focused on Iluzorov, use of Iluzorov on Charcot. So there are two focused societies. So I think we can collaborate on a variety of platforms, and we also want to collaborate with vascular surgeons, radiologists, and to make sure that, you know, we can maximize. Our aim obviously is to do limb salvage, right? I mean, that's what we want to do. So if we can increase, why do people lose limbs? Vascularity, right? I mean, ultimately they will lose the vascularity and or have these deformities leading to ulcers and so on and so forth. So these are the two things I think we can certainly do to save limbs. That's our aim. So that's why we have this society. So we want to welcome your ideas to see what we can do to form this society. And there are some initial, parameters or structure. You know, this is what we propose. Again, those folks who want to join the society, we can have a deeper discussion on how we should set this up and so on and so forth. You know, we'll have meetings in different parts of the world, right? I mean, you know, so we want to encourage awareness and gather ideas and learn from each other's experience from, say, in Brazil or China, where many people have started doing this. So that's our focus, really. So this is our initial setup. This is what we are hoping to do. We want to have different committees for scientific research. We want to have a registry, for example, to collect cases and ultimately, you know, increase awareness to public policy and so on and so forth. So this is just a brief outline of what we are hoping to achieve by establishing these two societies. So any ideas, anything, any exciting things, thoughts you have, guys, you let me or Alan know. And we really are excited to start these two new societies. And I think there will be a QR code and there will be application forms outside. And we really hope that you can make the society stronger.
And, well, we bring the world to us. And tomorrow we're kind of setting up a candy shop for all surgeons, especially, and also for all practitioners. We have Dr. Hua, who started the very first TTT surgery 26 to 30 years ago. And he's going to show his cases. And also we have our Italian surgeons group shows our Iluzorov techniques they use. And we have labs. So sign up at the labs, and tomorrow so we will see all the surgical techniques presented to us. So thank you. Thank you. So we will have Dr. Lavery come over on floor. So we have we leave time for the Q&A sessions and see if Dr. Busui will be here on time. So on the prevention part of diabetic foot, so which is so cost effective, and that really works for our patients population. So I have put a Q&A sessions here. I will start with the first question. So we're doing a lot of those surgeries, especially when it's the horse that's out of the barn, it's too late, arches are collapsed and all dislocated, so we have to do surgery, even if like the risk is high. And we have more and more kind of expensive, fancy tools there. So this is an expensive process. And what's the data shows the cost, the differences if you do a prevention and you prevented those people from progress to that, and what's the savable cost we can use, or even going to the stages we have to do those fancy surgeries, recovery. What's the differences with patient amputation versus you doing a limb salvage, if you have those data?
No, I don't know that there's U.S. data or European data that has done an economic analysis. So I'm not familiar with that data. And I think a lot of the healthcare economics guys, it's a different language. It's not like, oh, you save $75,000.
Right.
I mean, they're looking at quality of life years and stuff that I'm like, so I
probably a different medical system would make some differences also. So we would like to ask our UK colleagues, and if you guys have any data on the cost of saving, and how do you do prevention though? I find it's very difficult, institutionally and also individually. There is one thing that I learned, if I learned like the most obvious thing, those diabetic patients, they have PNS, that means they have CNS pathology also. So those patients, if you do not think they are non-compliant, but that's probably their pathology. This morning I had that session, I was asking that psychology component. How much is the psychology? How much is their physical pathology of their CNS and causing that kind of problem? So I'd like to hear what you guys do in UK.
So since our clinic became a unit, it's a day unit, our approach in addressing all diabetic foot presentations have changed a bit. So our goal is to provide a one-stop service so that prior to establishing the unit component of the service, it was a clinic, and whenever I saw any patient that needed prevention, small procedures, and then I used to put them on the waiting list and do them as day procedures. But I do most of those procedures now at the time of admission, but at the time of clinic attendance. So from that experience, we have made a very clear algorithm in our mind. We have written a paper as well on small procedures, minor procedures for diabetic foot presentations. And the previous talks covered some of them. So ranging from percutaneous flexor tenotomies for prevention or treatment of apical toe ulcers. And then, yes, if there is an isolated or selective tightness of the medial band of the plantar fascia, then identify it, because you tend to see the ulcer on the medial aspect of the hallux with rigidity in dorsiflexion. Then we just do under local release. Or if it is, say, a plantar prominence of the first metatarsal head due to relatively overactive peroneus longus, then we do longus to brevis transfer in the clinic there and then. Or if there is bone change in the hallux MTPJ, then a Koller procedure type, not very complex tendon transfers, but most of those. So yes, I think having access to that type of one-stop service makes us think even better on achieving your goals of this primary and secondary prevention for one of those presentations. So those are for most commonest forefoot presentations. But if there is a larger bone prominence in the midfoot, we can't do such resections in the clinic or in our unit, then I put them on the waiting list in day surgery, or major sharp foot reconstructions obviously have to be done. But because of our improvement in our understanding on such soft tissue balancing procedures for primary and secondary prevention, we're applying those principles more robustly in all surgical reconstructions. Whether it is, I don't remember the last time when I did an isolated exostectomy. It was an exostectomy along with tendon transfers, additional soft tissue balancing, whether minor tendon or major. And about 13 years ago, we made a deal with the vascular colleagues. Prior to that, all minor amputations and infections were admitted under the vascular team, and only deformities were referred to the orthopedic team, but we're still only one vascular consultant and one orthopedic consultant. But at that time, we made a deal that and agreed that we, the orthopedic team, take over all infection presentations apart from the ischemic presentations for debridements, minor amputations, because we always combine with balancing procedures there and then. So the secondary deformities, which used to be more common following transmetatarsal amputation of CHO parts or even hallux amputations done by our vascular colleagues, were actually reduced. So it's still a continuing learning process, but I feel that our understanding on this aspect, mechanical aspect, and mechanical corrections have improved significantly.
Sure. Yes.
What amazes me is, the healthcare dollars we spend, with these patients. So if you follow patients, I mean, you have extensive experience in this kind of patients. They first come with an ulcer, right? They come back, they get healed, IV antibiotics, admissions in the inpatient admissions for maybe 3-4 weeks or 6 weeks sometimes. Sometimes they get MRIs, scans. Sometimes they get a whole lot of unnecessary investigations. Don't lead anything to anywhere. Red swollen leg. They got a DVT evaluation. They got MRI. They got even lymphangiography in some centers. And then we spend hundreds and hundreds of dollars, and then we come back another ulcer, and then finally come to amputation. I'm curious as to how much healthcare dollars we spend on these patients because they're going down this road with multiple interventions, and it looks like we go down the circle again and again. So, isn't that crazy, right? I mean, ultimately they end up in amputation as well, some of these folks. And what do we do? I think the answer is education. I hope we can educate our patients, we can educate our carers at all levels, whether it's primary care doctors, GPs, because they need to pick things up. I've seen even internists say, I'm not blaming anybody, but again, it may be lack of education or what. A lot of patients are mismanaged. Yes. And we see, okay, my God, if we go through those x-rays, if these patients have been in your institution, I could have prevented that. I could have prevented an amputation. I could have prevented a number of admissions. We see this time and time again. I think we should all do a lot more to the society by educating. I think there's a lot more we can do on this.
Okay, sorry. Okay, so the other question that I have, so that catch my eyes for that temperature monitoring that you have mentioned. So, and you have done studies, the preliminary results, and what do you see? And that's a simple way of monitoring people. And those patients got all kinds of problems with social issues. We get into that problem. I promise this is not only my experiences. Everybody has that. They do not have transportation. They do not like to come over, and they do not have helpers at home. So do you think, what's the potential, you think, the temperature monitoring, and would that have like confounding factors affecting your results? How effective would that be?
So I think there's a really nice body of work, people using different approaches, but probably 5 of the 10 studies use the same temperature monitoring device. And I showed the prototype in my slide. Literally, we had one of the engineering students went to the hardware store, and that was $12 worth of hardware parts. And so now those can be made very inexpensively. And there are very, very expensive models that, unless you're an organization that is, not worried about reimbursement or whatever, but for most, if you're just going to deliver that to the patient, you can probably get them a device for $30 or $40. If you look on the internet, I mean, there are infrared cameras that go on your phone. You know, there's a bunch of ways to do it. You know, probably the best method, or there's a couple companies that have a device that Bluetooth to the internet. They can analyze your data and give you feedback when you're out of range. Or, you know, so if you live 2.5 miles or 2.5 hours from Sioux Falls, you can come in, you know, twice a year and still have communication about, you know, what's going on with your foot. So we started using it to identify people before they ulcerated. The window from injury to ulceration is like 37 days. I mean, it's not, I mean, I was really trained. You injure your foot, the next day you're going to have an ulcer. It's, you know, it's long. We've used it in clinic to look at people that had lower extremity endovascular procedures and their stent goes down. So,
yeah,
you know, that angiosome gets hot, or gets cold, I should say,
yeah,
you know, 2 or 3 or 4 degrees Fahrenheit down from their serial measurements. We've used it in the clinic to look for people that were warm, that were you know, infected before they had clinical signs of infection. So, I mean, there's a lot of ways to use it in clinic, but really affordable ways for people to use it at home.
Yeah, there was always interesting in those like a simple ways, like, you know, you have like your charcoal attack. You measure the temperature differences between those two foot. Now, is there any data on specific, you know, sensitivity and specificity of that temperature measure for monitoring?
So there's 2 really nice papers. One was a cohort, I think 139 people. Bob Freiberg was the PI. It was published in Diabetes Care. It's probably 5 or 6 years old. That it wasn't an intervention study. People just took their temperatures. So, you know, some people ulcerated, and so you can see their progression, their temperature change over time until they ulcerated, and some people never ulcerated. And so, like most patients, they also had a foot that never ulcerated and one that did. So you could compare, and that study mostly compared their right and left foot and temperature changes within their feet. And then there's a follow-up study that looked at people that had below knee amputation. So obviously you don't have a comparison leg, that I was the PI on, or the first author on, and that was in, I think it was in the British Medical Journal Endocrinology or something like that. So they have all the diagnostic characteristics: sensitivity, specificity, diagnostic odds ratio, positive and negative predictive value. So, you know, I think those are the only 2 studies that have looked at the diagnostic characteristic, but there's data out there to build on. Uniformly, we did a sensitivity analysis to see if 4 degrees Fahrenheit or 2.2 degrees Celsius was the trigger. Completely stolen from what Paul Brand said. That wasn't, you know, we didn't sit around and go, oh, I know it's 4 degrees Fahrenheit. That's what Paul Brand said 30 years ago from observing people. And it turns out when you do a sensitivity, the best trade-off between sensitivity and specificity is 2.2 degrees Celsius. Paul Brand was right, just observing people.
Yeah. All right. Thank you. And that seems to me, you know, it's we can do still a lot, right? And the standard of care is still like a kind of like a, you know, for me, is not very clear. So any other questions from our audience? Yes.
I think one of the key parts of the prevention aspect, sorry to go back to it, is as you put down as the levels of risks. Because for any cancer, any prostate cancer, breast cancer, you name it, there's a screening program for it. And I think the diabetic foot, the screening program is the level of risk and the frequency at which the patient should be seen. And I think even in the UK, that's where we're still struggling with, and I'm sure it's the same in most areas. Everyone sort of thinks about, oh, they should just have annual review. But just as you clearly illustrated, as the risk goes up, they need to be seen 1 to 3 monthly for the high-risk group. And I think that's where the reoccurrence bit is. No matter how much education we do, like I showed you with that picture, there is no connection between the CNS and the foot. that, excuse me to say, we've got patients who are lawyers, solicitors, accountants, people who are well educated. And they come in, Mr. Smith, why are you not wearing your orthotic shoes? They'll give an excuse. It was just a party, and the shoe rubs. So there is a very big deficit there, whether it's cognitive or we call it the diabetic foot on awareness. But I think the cornerstone is really having the regular follow-up. And at some point, we used to be able to follow our patients up every 3 to 4 weeks, those who were quite worried about, and they remain intact because they know they are coming to their appointments, they wear their offloading and so on, so they are forefront of their mind. But as soon as we get loaded up and we extended the appointments and bring them back in, you name it, even when they've got a wound and we cannot see them within a week, they come back on 2 weeks' time with the same dressings on. So I think similar to as we use the cancer aspect, we need to let the, be it the government or whoever, know that these patients need to have their review appointments as a standard. If it says they need to be seen every 1 to 2 months, they have to have that screening bit. If it's every 6 months, they have to have that for the moderate risk. High risk, if it's saying, every 1 to 3 months, we have to see, are we delivering that? And I think that is where the key aspect to prevention perhaps is.
That will increase your waiting list.
Sorry?
That will increase your waiting list.
It is, but then it tells us.
I know, but
it's like if you have
breast
cancer or cervical cancer and you need to do the screening.
I'm kidding. Because, your primary care or GPs do see patients all the time anyway, right? Annual checkups and so on and so forth. You're right, absolutely right. Testing the sensitivity should be part of the screening program, and hopefully we'll catch them up early enough and at least, help them. You're also right about the disconnection from, Michael Pinzur used to say, nerves are made from the same material as the nerve, and the brain is the same thing. So, if it's affecting your nerves, it's affecting your brain too. So I think that probably is a reason for the lack of compliance to be.
Deposits cannot pass the blood-brain barrier.
Yeah.
So
yes. Same process, right? Yeah. Do you think Dr. Koller is there online to answer questions also or not? Probably not, right? Because he has shown a different perspective altogether. Because obviously over the years we have started off with smaller screws and bigger screws and bigger screws and bigger nails now, and he's showing the other way around and saying that it's going a minimalistic approach. I wanted to ask some questions with him, but because I do share some of his thoughts, because ultimately we are all learning. And
all right, very insightful discussions, and thank you very much for everyone. So that is our didactic session today. And tomorrow will be more shifting the construction of our forum. It's still multidisciplinary, but tomorrow will be more techniques in the surgical aspect. And we have labs for surgeons and non-surgeons. Please sign up, and tomorrow we will have a blast. That has been a blast for me, so I'm sure everybody will enjoy it.